Good morning and afternoon. This is Peter Eckert from the Illinois Public Health Institute in Chicago. Welcome to Big Cities, Big Data, Big Lessons. We're going to get started in just a second. As folks for the webinar, I'd like to introduce you to the primary way that you're going to be participating as an attendee. Because we have so many people who wanted to participate in the webinar, you'll stay in a muted situation and then use the chat box. And then in the chat box is where you can send us comments and questions. We've had really good luck with this in the past, and so we encourage you to be prepared to ask questions. We are setting aside a good amount of question time at the end. So we again, hope that you'll share your insights and your questions. Today's presenters are all coming from Data Across Sectors for Health. DASH is a Robert Wood Johnson Foundation National Program Office launched just short of 3 years ago to support multi-sector local data sharing efforts that are intended to increase community capacity to address health and health equity. DASH originally made 10 $200,000 grants, and our 4 presenters are 4 of those grantees. DASH is also a founding partner in All-In Data for Community Health, and we welcome our All-In partners who are participating on the webinar today. These are the 10 DASH grantees, kind of strung around the edges of the country. Then also, All-In incorporates another 50 communities across the country. All-In is a network of peers and projects who are all interested in the same work of building the capacity of local organizations who are taking a multi-sector approach to sharing data. As we're getting close to 75 people joining us, and so I'd like to move to our presenters and introduce you to the moderator for today. Our good friend and DASH advisor, Carrie Hoff from San Diego, will be moderating today's panel. Carrie is the Deputy Director at the Health and Human Services Agency of San Diego County, and so has a deep well of experience and knowledge about what it takes to make multi-sector data sharing work in an urban center. We're also joined by 4 representatives from DASH projects: Kevin Conti from New York, Karen Hacker from Allegheny County, Amy Laurent from Seattle, and Darcy Phelan Emmerich from Baltimore. The 4 of them will share the stories of their work, and then we'll go for questions. I think we're just going to get started, and I'm going to turn it over to Carrie.
Thank you, Peter, and welcome to everyone. I am really excited to have an opportunity to moderate this session. As Peter mentioned, I do work for the County of San Diego, and I have been leading our effort to bring data across different sectors together, ranging from eligibility and child welfare to alcohol and drug services and mental health and probation, public health nursing, housing. And so I come to this from the side of the house of the mechanics of bringing the information together. But the panelists today really excite my interest because these are leaders who have not only taken the step of looking at what needs to come together, but they have actually integrated the data and put it into action. And that's really the ultimate activity we want to reach in order to make a difference in the lives of the people we serve. So that is really part and parcel what the Data Across Sectors for Health National Advisory Committee has been working on. Really, how do we activate, support, and even accelerate the work of using data across sectors for health in the broadest sense? And so We're going to start with Kevin Conti from New York City, and he's going to share with us what he's worked on and their discoveries and observations as they've done their work looking at data from multiple sectors.
Well, hi, I'm Kevin Conti. I'm from the New York City Department of Health and Mental Hygiene, and it's very nice to be here to talk to y'all. It was also nice to be at APHA and in the session there. So I'm going to talk about neighborhood tabulation areas, enhancing population and health improvement capacity in New York City through shared information at the small area level. Next slide. So our project in New York City had a straightforward objective: to work with partners to bring together health and social determinants of health data at the neighborhood level using a new geographic scale, the neighborhood tabulation area. Next slide. And our partners for this project were a number of other city agencies. So it was the New York City Department of Health, the Department of City Planning, who originally devised the neighborhood tabulation area for population projections. The Center for Innovation Through Data Intelligence, which is a data shop for the health and human services agencies that are included below, including the Department of Correction, Department for the Aging, Department of Social Service, including Homeless Services and the Human Resources Administration, as well as several organizations, including the New York Academy of Medicine, the United Hospital Fund of New York, and the Fund for Public Health in New York City. And so our motivation for this project came from and stemmed out of the increased focus on social determinants of health and an acknowledgement of their importance, and realizing that health data often lack social determinant of health information, and the necessity of linking health with census and other data at a census geography, so that we could take advantage of both using compatible scales. And so, and it came out of the question of what was the optimal census geography for neighborhood health. Right. So currently, neighborhood can be defined in New York City using the community district. There's 49 community districts in New York City. They are the geographic level at which we produce our community health profiles. There's a number of benefits to using CD. They're critical geography for computing, community planning, and decision making. Each CD approximates a PUMA, that's by design, design of the PUMAs actually, public use microdata area, which are readily available census data. And so we already release data at the community health profile level. There is a limitation to these, though, is that the median population of 140,000 may mask potential heterogeneity. And even more basic than that, it may be a scale that's coarser than our actual notion of what it means to be a neighborhood. So the neighborhood tabulation area is a statistical area created by Department of City Planning in around 2007, 2008. It's an aggregation of census tracts within the same PUMA. So NTAs form together to make PUMAs, which are approximations of community districts. There's a minimum population of 15,000, and they're a useful geography for assessing and analyzing neighborhood health. And they have a number of desirable properties for looking into community health or population health or doing neighborhood health assessments. First of all is their granularity, in that they're fine enough to capture neighborhood. Secondly is their reliability. Oftentimes an impulse in doing this sort of community or spatial analysis is to default to or attempt to get data at the finest geographic scale possible. And that actually raises reliability concerns when bringing it together. They have a correspondence to neighborhood boundaries, and that's because the official city demography divides them to be such. They're spatially congruous. They have a temporal consistency. Unlike zip codes, which might change every couple of years, these are defined and maintained by a central body within the New York City government. And compared with other geographies with available census data, we believe they generally represent the best trade-off among these desirable attributes. So NTA is more granular than CD. So these are a couple maps, and on the left you can see premature mortality rates by community district in New York City from 2009 to 13. And on the right you see, with the same borders for community districts, you can see the same map shaded by community district. I mean, by NTA. Okay, next slide. And you'll see, oh, back a slide. so you'll see in the green circles are areas where within community district we see variation at the neighborhood tabulation area. So for instance, in the North Shore of Staten Island, which is the island on the bottom left, you can see that the community district there has quite a bit of heterogeneity. All right, next slide. And this here is a picture of Coney Island from the last map. And this is the age-adjusted premature mortality rate in that community district. And the CD premature mortality rate was 218 per 100,000. And you can see by looking at the NTAs within that community district that it varies quite a bit. And most of the, and that there's three areas, Gravesend, Brighton Beach, and West Brighton, that have premature mortality rates, half of that of the other NTA, Seagate, Coney Island. NTS estimates are also more reliable than census tract estimates. These are two maps, and on the left and the right, the left you have census tract poverty estimates shaded by whether or not the estimate that you can make at a 5-year ACS data is reliable using the coefficient of variation being below 20. Now this is actually a very lax version of reliability. And even with a lax version, you can see that most of the city, the actual poverty estimates, which is one of the core indicators, most of the city does not have a reliable poverty estimate. On the right, you can see the same with using NTAs, and you can see we can cover most of the city with reliable NTA level poverty estimates. And so unlike zip codes, neighborhoods also correspond to historic neighborhood boundaries. And I actually think this is one of the kind of the less appreciated of the different benefits of using this sort of geography. I mean, zip codes obviously have a lot of currency. Everybody knows about zip codes, everybody uses zip codes. But most people are aware of the zip code that they're in without really, in a place like New York, being able to digest zip codes for areas that aren't related to them. Whereas using neighborhood boundaries and having with that neighborhood names for your areas actually allows you to digest the information much easier, and I think this is a real benefit. So what data sources are going to bring together? So for this project, we brought together American Community Survey data. Now this we're accessing through the Department of City Planning, who has put a lot of work into not only processing census tract information that you get from the American Community Survey, but then rolling it up to the NTA level and then providing confidence intervals and variance estimation for those NTA-based numbers. Right? From the New York City Department of Health and Mental Hygiene, we're going to bring in vital statistics, disease control, environmental health, the A1C registry, and we're able to bring in any other disease registry that we'd like to. And then from other city agencies, we have partnered with the Administration for Children's Services, the Department of Social Services, including HRA and Homeless Services, Department for Aging, Department of Correction, and the Department of Education. From the Sparks data set, which is a sort of all payers, not quite all payers, claims database in New York, we have ED visits and hospitalizations. We have New York City Medicaid data, health data in New York, and New York City open data. And together we can bring it all together and make 100 indicators that have been created and made using these above data to assess social determinants of health. So our key project activities were inclusion of the 100 plus indicators, improving and implementing automated geocoding routines, which allow us to move from, for instance, a disease registry into NTA coded information. DOH MH produced population estimates for each year at the NTA level, data dissemination and an interface in order to access data, and the development of various use cases. So here's a few of those data uses. So first is to identify health concerns and disparity at the neighborhood scale. So we can use this for targeting by monitoring year to year for surveillance, and also by monitoring year to year and taking into account our spatial, any interventions we're undertaken on a spatial level to do evaluation. So we can identify pockets of high burden outside areas, and this has helped us to develop new neighborhood health action centers. We can uncover social determinants of health in communities. We've done a couple projects, premature mortality and jail incarceration, where we're looking at both premature mortality and its relationship to jail incarceration levels at the NTA level. We've looked at Legionnaire's disease and cooler towering death sensitivity to NTA level. For emergency preparedness, NTAs have allowed us to use the ACS microdata and to create to identify areas that have high levels of, for instance, senior citizens or people with disabilities for emergency response. And they help drive community prevention planning and investments. So our Take Care New York neighborhood health initiatives of investments, UHF Medicaid Institute reports, and we can produce a number of reports at this level. But much more than that, we can partner with community organizations and produce information at a level that's meaningful to not just to us, looking down from the citywide level, but to them working with the community. And then there's a number of potential uses. So long-term cross-agency surveillance and reporting, I think anyone in this field would realize that, would recognize that getting agencies together, agencies' data together for longer-term surveillance and reporting would be a great benefit to public health. And so the expansion to other agencies is really important. Being able to systemize our initial efforts just has an additional payoff. I mean, we can do this once and produce some maps and generate some knowledge, but being able to watch it from year to year has such an additional benefit. Neighborhood tabulations of area information allows us to develop and use hierarchical multi-level modeling. So, for instance, we can take health surveys in which we've asked detailed questions of participants and then attach on context information from these models. It allows us to do ecological cost exercises, for instance, relating NTA level rates to hypothetical gains from, for instance, dropping an NTA level rate down to a lower rates, and then doing a cost exercise. And then for long-term planning, so I mean they were originally constructed for long-term population projections, and so NTAs do come with sort of a 30-year time horizon of a population projection. And it's interesting to think about the possibility of using those projections in order to, using those population projections to play out scenarios. For instance, what is the 20-year burden of diabetes across neighborhoods? And then lastly, without a doubt, a major benefit is the increased cooperation and coordination between agencies, with community partners, and then with the public. So yeah, to conclude, the NTAs represent a useful geography to organize New York City data to examine and promote neighborhood health. And issues with incorporating survey data, such as community health survey, represent a potential limitation, but one that we're definitely working on. All right. So, of course, funding for this was from the DASH grants, and the project was led by Sui Sao within the New York City Department of Health and the Office of Policy Planning and Strategic Data Use, and he led it the entire time. And so, much thanks to him, and also special thanks to the Department of City Planning, who's been an excellent partner in not only giving advice but maintaining sort of an advocacy for the maintenance of this geography. And the Center for Innovation Through Data Intelligence, who's crucial to our relationships with the other health and human services agencies. All right, thank you very much.
Thank you, Kevin. I had a clarifying question for you. Before embarking on this specific effort, how much of a history was there for data sharing across the sectors you named? Because, you know, a lot of this data ranging from the city to the hospitals and EDs and education, It's very desirable, but it's not always easy to overcome some of the first hurdles of building those relationships. So how much of a history pre-existed this project, and how much did you have to work on as a part of the project?
Well, I will say that, this project started at a time in which it was definitely appreciated that cross-agency cooperation would have a benefit, but it hadn't been done much. So there were already talks ongoing about different use cases in which data sharing would be a benefit. But this project actually, one thing that it did was by identifying a geography that wasn't the individual level, so it didn't necessarily involve individual level matching, it allowed agencies to come together at an aggregate geography that would more readily allow them to share data, and which then put us at the table with the other agencies to talk through how we're going to share this data at this level at which we all agree to. And I think that actually sitting at the table will eventually lead to individual level data sharing. So in some ways it was excellent to have an aggregate level to go to in order to start these relationships, or to make the relationships much more bountiful.
That makes a lot of sense, and I do agree with you that often just getting the footing and the understanding and the levels of trust is an enormous enabler, and it sounds like this effort has really done just that.
Yes.
Great. All right. Well, now we're going to move on to a presentation from Dr. Karen Hacker. She is with Allegheny County, which has long been a leader in the area of bringing data across sectors together for really working with the families and individuals as a whole person. And she's going to share about her efforts centering around cardiovascular disease.
Hi, this is Dr. Hacker. I think you skipped my first slide there. Nope. Well, I guess not. Okay, I just wanted to say hello to all. I'm from the Allegheny County Health Department. I'm the director there, and I'm going to be talking today about the Allegheny County Data Sharing Alliance for Health. It's a bit of a mouthful, but the focus here is on using multi-sector data to create a warehouse and then to model that data to inform policies on interventions focused on cardiovascular disease. So this first slide gives you a sense of Allegheny County. For those who are not aware of Allegheny County, we're in southwestern Pennsylvania. We're a county that includes the city of Pittsburgh. We've got about 1.2 million people. And we have a very unique, I think, history in terms of the steel industry and the demise of the steel industry in the 70s and 80s, leaving many of our river communities in a very high level of disadvantage. So what you can see in this slide is the poverty level across those communities. Pittsburgh, by the way, is in between the two rivers, for those who are not aware of it. And then as you begin to go out the rivers, we have a number of much smaller communities. Total is 130 municipal governments. We have a very large group of organizations that have come together for our plan for a healthier Allegheny, which is our health improvement plan. And we chose to use this as our starting point. From that group, we engaged a number of pivotal partners in this particular project, including a number of our managed care organizations, 3 of them to be exact, and these are the 3 main ones in our county. There were also a number of government organizations that joined us, including our economic development folks and folks from traffic, those types of areas, Port Authority. And then we also engaged many of the universities as they have additional public data. Much of the data that we're talking about today, without that of the managed care organizations, is actually public-facing data. Next. We've decided to focus our attention on cardiovascular health because this is, as is the case in many jurisdictions, our leading factor for mortality. And we also thought that it would give us a sense of what was going on around the entire county, because the risk factors for cardiovascular mortality are also other issues that we're contending with, whether it's hypertension or tobacco smoking or physical inactivity. But we also wanted to get at some of the social determinants, which we thought were related to heart disease. And those include things like economic data, We actually looked at exemptions to our statewide smoking ban, our built environment, our food access, and we also have a fair amount of environmental health data since we are the organization that oversees air quality in our area. And then the objective was to pull all of this into a single accurate model ultimately with the University of Pittsburgh, which I'll talk about a little bit later. But first and foremost, it was to pull it into this warehouse and determine how much of the data we could actually make public. So this gives you a sense of the type of data that we pulled. There were actually other opportunities for data, but we thought these were the most related. We could create a rationale in our minds for how these might relate to cardiovascular mortality. You know, obviously in the health inputs, things like hypertension and diabetes and hyperlipidemia claims data, we asked the managed care organizations to give us the percent of members with a given diagnosis who lived in a particular census tract, and they were willing to do that. We had to give them all of the definitions for this so that they understood exactly what it was that we wanted. And we were also looking in some cases at sort of comorbidities when an individual, for example, or a number of individuals had all of those diagnoses during a given year. We also included anxiety and medication and depression medication information as well. Remember, this is all de-identified. This is all percent level data essentially at the census tract. But then we also have data on the natural environment, including air quality and land use, a whole variety of social information from demographics to access to transportation, homicide and violence, as well as mortality and vital statistics data, and then a whole variety of data on built environment. We in Allegheny County have been working extensively with economic development, so a lot of the information that we gathered from them were things that ranged from vacant properties to home ownership and things like that. Next. So the first step I wanted to just show you was we initially started with only one of our managed care organizations, and when we looked at the data for that group, it only really covered about 30% of our entire population. When we were able to bring in 2 additional managed care organizations, which covered not only publicly funded, i.e. Medicaid populations, but also included the largest commercial insurer, we got up to about 60% of our insured population. Now, we know that there are certain groups that are not covered, and you can see here in this data the areas of our county that we knew we had much lower coverage with these 3 insurers. It would be great if we could get all insurers in our county, but we thought we were doing pretty well with the 3 major ones. Next. And then we began to look at things like cardiovascular disease deaths, and here it is overlaid with the rates of vacant properties. Like so many jurisdictions, we're using GIS extensively at this point in time, and using this data and having this data available has given us that opportunity to do all these overlays now, looking at things like vacant properties, poverty, all those types of things, along with cardiovascular death. And it did help to pinpoint some of the most risky communities. This data will have a life long after this particular project. We've already been talking about new information that we can collect, particularly from our managed care organizations. For example, we're planning to go into asthma, perhaps opioid deaths, things like that. But all of this other data will remain now, by the way, in the public sector. And our 3 managed care companies agreed that as long as we pulled all the data together, that too could be available for the public, and it is currently now available. I'm going to talk a little bit now about our work with the University of Pittsburgh and their framework for reconstructing epidemiologic dynamics. This is a synthetic model that they have created, initially created to look at how infectious diseases traveled in a certain area. They're now adjusting this to look at chronic disease. And our initial thought was that if we could export the data we were collecting to this model, that we would have the opportunity to not only look across all of our communities in terms of targeting interventions, but also even look at how a particular intervention might impact the outcome that we were interested in. Next. So unfortunately, as we moved through this, what we began to learn is that many of the areas that we were interested in that we call social determinants did not have anything in the literature that pinpointed the kind of impact that they might have on cardiovascular mortality. So we had to come up with another strategy, and that was to look at the predictive risk knowing what we knew about these communities, and then the actual mortality, and then to look at the difference as the expected minus the observed risks. And that would help us determine when and if many of these social determinants were actually impacting this particular outcome. So you can see that there are differences here. Some of the communities are their predicted risks and their actual mortality are right on the money, and others are not. You will notice that we particularly have these communities in the southeast portion of our county. Again, these are areas that we know have been left with a high level of disadvantage following, as I said, the loss of the steel industry. There hasn't been a lot of replacement in these communities. Property values are pretty low, but they also have a whole number of high risks in those communities that we're aware of. So as we looked at this difference between observed and expected by census tract, we then started to model whether or not changing any of these social determinants would actually make a difference. And this shows you specifically the number of social determinants in the lower corner: food stamps, obesity, percent of housing in poor condition, percent of vacant housing, diabetes, and hypertension. And we pulled all of those together almost like an index, and then we're able to say if we were able to reduce those by 40%, what would we see in terms of cardiovascular risk? And I think this is a nice depiction of the improvements we would see, but I think it's important to note that there are still communities that really don't seem to move, even with a 40% reduction in all of these things, which, as everyone knows, would be very difficult to implement. So I think the top lessons that we've learned using this data is that we can really, what is the data that really determines the direct impact of these social determinants on cardiovascular disease, and how much of that is lacking? And so we really urge researchers in our community as well as others to consider that, because I think it would be very helpful for all of us as we really try to look at the evidence for impacting these social determinants. Clearly, for us to get all of our major insurers to the table and involved was absolutely critical to getting a fair amount of coverage across the county, and that relationship will pan out for future work as well. But in the long run, what we also learned was it was very difficult to get everybody then to the table once we had this information to agree on any single one intervention. So here, at least in Allegheny County, we're allowing for independence. We have taken this information to all of the stakeholders, including the larger advisory coalition, to think about different strategies that could be implemented in particular communities. Probably the one that we've had the most success with is the American Heart Association, which is now targeting its blood pressure program to the communities with the highest levels of cardiovascular mortality. I think there's 60 of our 130 municipalities that they're working in. So for our next steps, we are looking at possible interventions, continuing that work, but we are also thinking about how we can use this data in the long run to refocus on other outcomes. As I mentioned before, we're interested particularly in asthma and opioid overdoses, and that work is actually going to start very soon. We're going to continue to work with our colleagues at the University of Pittsburgh to refine FRED and see how we can use it to better model interventions. We're hoping that with an outcome like asthma, we may have interventions that we can understand the power of much more clearly and perhaps model more effectively. And then we are planning to sustain this data over time through our collaborations. There's not going to have to be any new resources to implement that. And I think that's the end of mine.
Great. Thank you so much, Dr. Hecker. I did have a clarifying question for you. You mentioned something that caught my attention, and I think can often be underestimated as an underpinning to efforts like yours, and that was you talked about coming to a consensus or providing the definitions for the metrics that you wanted from the different participating entities. And I wanted to know, how much time did that take, and was it a collaborative effort or one where you centrally made the definitions and then provided those out, that data governance element?
So what we decided to do was actually look for definitions that already existed, and I was lucky enough to have colleagues who had worked in the HMO research network, which folks may be familiar with. So we reached out to them, and they were able to give us a very updated version of diagnostic codes and medication codes that could be used. We then circulated those to all the partners to make sure that they were fine with them, which they were. we drafted a very extensive rubric, essentially, for them to respond to. Once they felt that it was comprehensive, that's when we sent it out to everyone.
Wow, that's great. That does take a lot of work. And I don't think it's always maybe thoroughly understood or anticipated before embarking on something to get to the end result you have. So that's a lot of work.
Well, the other thing I was going to say is that even the question of defining for the managed care organizations what books of business you wanted and what years and eligibility requirements, enrollment requirements, all those things had to be really, there had to be consensus, because otherwise we'd end up with different data sets that couldn't actually be merged together.
Yeah. So about how much time did that take overall to get those definitions pulled together and agreed upon?
I think that was, well, the bigger thing for us is that we were still pulling in managed care organizations up to about 6 or 7 months into the project. We had started with one that agreed, and then the second one came on board. The third one was the most difficult. So once we had them, I think we started doing the definitions fairly rapidly. I want to say maybe that whole process took 6 to 7 months.
Okay. Wow, that's great. Great. Well, thank you so much.
You're welcome.
Next, we will be hearing from Dr. Darcy Salon Emmerich, and she is reporting out on a Baltimore project relating to fall reduction. And she's going to share how they looked at data from multiple sectors to really try and pinpoint how to reduce falls and the impacts they have on people's lives.
Well, great. Thank you so much for having me. Again, and for the introduction, my name is Darcy Phelan Emmerich, and I'm the Chief Epidemiologist at the Baltimore City Health Department, and really appreciate the opportunity to be on the webinar and to share with you our work on falls reduction. And so just wanted to include here that we have no financial disclosures regarding any of the details in this, and this is a holdover slide from our presentation at APHA. And first wanted to present on the background of falls. So in 2015 alone, over 3 million older adults were treated for falls in emergency departments in the US. So 3 million people is about the population of Utah. So this is a huge number of older adults being treated for falls in the emergency department in 1 year. And all of this is despite knowing that we have effective falls interventions that include exercise, home modification, vision screening, taking a look at medication management, and so forth. So there's a large public health burden, and we know that there are evidence-based effective interventions. So combining that here in Baltimore City with our local health information exchange, we wanted to leverage our HIE for public health use cases, including surveillance for falls. So here in Maryland, our health information exchange is called CRISP, and that stands for Chesapeake Regional Information System for Our Patients. So we've worked with CRISP, our health information exchange, which covers the entire state of Maryland. It's comprehensive. Other partners include the Baltimore City Housing Department, our Baltimore City 311 system, which is what citizens can do to submit requests for service. We have social service providers, hospitals in Baltimore City. There are 11 acute care hospitals just right in the city. And we also are working with academic institutions. And so putting all of these sectors and groups together, we've created a collaboration known as BeFriends. And again, BeFriends stands for Baltimore Falls Reduction Initiative Engaging Neighborhoods and Data. And so it's a collaboration between us at the Health Department, CRISP, our Health Information Exchange, and our many partners. And our funding for the infrastructure for BeFriend was provided by RWJF, the DASH program. The overall goal of BeFriend is to decrease the rate of falls leading to hospitalizations or emergency department visits, among older adults by 1/3 in 3 years in Baltimore City. So in order to accomplish that goal, what I'd like to focus on is really about the data. So the data, methods, and how we're using the data to inform interventions. So our surveillance population is older adult residents of Baltimore City, and the time frame of interest is starting in October 2015, and that's when ICD-10 was implemented, and we're following forward to present. Our data source is the Maryland Health Services Cost Review Commission, which we affectionately refer to here in Baltimore City as the HSCRC. So the Maryland HSCRC provides emergency department and hospitalization case mix data with unique identifier to identify patients across institutions. And so this data source essentially captures all emergency department visits and hospitalizations across the state of Maryland. And so we're, of course, focused on Baltimore City. The outcome that we're interested in here is falls-related emergency department visits and hospitalizations. And we identified these falls-related visits through ICD-10 codes using a methodology developed in part by the CDC. So the overall goal of developing this infrastructure and using the falls surveillance is to really inform our community partners in Befriend about ways that they could consider focusing their services in a certain subpopulation or a certain part of town in terms of falls interventions. So the data that I'm going to present next are actually data that we shared with a coalition that had come together to focus on falls prevention. And they are focused in a certain zip code in Baltimore, and that's known as 21211. So the data that we have here are the number of falls-related ED visits and hospitalizations by month from 2015 through August of 2017. And as you can see, we have some variability by month. We drop as low as below 10 to above 25 by month. And so that is just within the zip code within Baltimore City. And again, the unit of observation is emergency department visit or hospitalization among older adults. So we can see there's a lot of heterogeneity here over time. When we look at the data, presenting the data, breaking it down by sex and race, about 70% of falls-related visits are among patients who are female. And for race, about 82% are among the white population. And so that breakdown of 82% white, 17% black is very different from the overall makeup of Baltimore City, which is about 2/3 black or African American and 1/3 white. So this zip code 21211 has a very different racial makeup than the rest of Baltimore City. When we look at the number of falls-related ED visits and hospitalization by age in the zip code, we see that they range from about 130 to about 150. So across the age groups, somewhat similar numbers, just looking at the raw number of falls. So next, I'd like to present on the number of falls-related visits per patient. So generally, our unit of observation is an emergency department visit or a hospitalization. And of course, a given patient could have one or more visits during the time period. So what I'd like to show you now is the number of falls-related visits per patient in the zip code per time period. So we can see here that 80% of our falls-related visits, 80% of our patients rather had just one falls-related visit in the time frame. But you can take a look at that yellow piece of the pie, the 17%. So among those with falls-related visits, about 17% had two during the time period. And so these would be the folks who have had multiple visits for falls within the time period. We could consider them being at having an increased risk of falls, and we know that even having one fall, for instance, can increase the risk of having another fall. I also want to say that in addition to the data that we presented here, we're also looking at the data by rates, so examining the data by rates and subpopulations in census tracts in Baltimore City. There are 200 census tracts in the city. And we're also looking at something that we refer to as excess falls. And so excess falls are calculated by comparing the observed number of falls-related visits to the expected number of falls-related visits. And we calculate the expected number by applying the citywide average rate to a census tract's number of older adults. So when we compare the observed to the expected, we get what we refer to as excess falls-related visits. And this is a concept that Dr. Hacker referenced in the prior presentation of looking at what you would observe versus what you would predict or expect. We're also working on starting some epi analyses as well as looking at spatial and temporal clustering. So just wanted to give you a bit of background on the additional data work that we're doing. In terms of lessons learned, we have certainly learned that working across sectors is more difficult than one expects. I mean, going into this, I really expected it to be difficult, but turns out it's even more difficult than that. So that really surprised us. We also found that local government bureaucracy and politics presents notable challenges to innovation. So the contracting process, of course, can have a lot of bureaucracy. Here in Baltimore, we had difficulties due to a mayoral election. Our mayor did not seek re-election, so we had a mayoral election in 2016, and that led to changes in leaders in the housing department as well as at the city solicitor's office. So that also complicated some of our legal agreements. One of our big lessons learned, though, is that local and meaningful data can really excite partners and create momentum for real change. And that's what's been the most exciting part of our work, is actually seeing how our partners want to use the data and how they can target their resources to focus on falls prevention. So in terms of next steps, we're going to continue using our data for surveillance and targeting falls prevention activities. We're working on a citywide falls prevention strategy that will be released in the next couple months. We're also working on incorporating additional data sources with our partners at EMS about calls for service related to falls. Our transportation section department is responsible for repairing sidewalks. So we want to look at citizen requests for sidewalk repairs, our older adult home visiting programs, and the weather. And then we're also working on conducting further epidemiologic analyses as well as geospatial analyses or hotspots. And so with that, if there are any clarifying questions, I'd be happy to answer them.
Thank you so much. Yes, I did have a clarifying question before we get into the open Q&A. You talked about the challenges of how hard it is to get to the point where the data is coming in and being shared across sectors. But I also noticed that you talked about how then having the data and the results you have does excite partners. Do you feel like this has progressed to a point where now people see the results and it's a little bit more mature and potentially, how would I say, protected from some of the political or leadership changes that naturally happen in any place? Or how are you feeling about where it is in that sort of maturity?
Yeah, so our partners have been like super excited to see and use the data. And our colleagues at Housing, who are not the new head of Housing, but a little bit below in terms of the leadership, they were actually able to send me a list of addresses of housing developments for older adults that they were interested in using, making improvements to those facilities. And I was able to look at our dashboard and look at our data and let them know how many falls had occurred at the given facility. And we were actually able to calculate a falls-related visit rate per unit for the different housing locations. And so the housing department was super, super excited about that. So I do think that as folks see the utility of the data and how it can improve their operations, that it gets them excited and it does really build momentum. And I think appreciate all the hard work that went into it and also want to continue to contribute towards it.
That is great because it's that front end is a big hill to climb, but knowing that the payoff can help secure what any of us are working on to sustain the test of time is encouraging to get through that hard uphill part. So thank you.
Yeah, it's been super fun to actually see like the data in action. I mean, I totally love the epidemiology and all the infrastructure, but now that we're at the community implementation part, it's super exciting.
Definitely. That is great. Well, we are going to turn to our next and final presenter. Amy Laurent from King County has been working on an effort to improve public housing residents' health and well-being. And she's going to speak to us about what they've been working on and what they've learned.
Hello, everybody. It's my pleasure to speak with you today about the King County data across sectors for housing and health. Next slide, please. Thank you. So as part of the background, you might wonder, well, why does housing matter to health? Well, for one reason, Public Health Seattle King County has a really strategic emphasis on both equity and the social determinants of health. Housing is an important contributor to the social determinants of health. If you look at the image that's on the right, Robert Wood Johnson Housing and Health Report had focused on some components of housing and how they influenced health, thinking about your housing quality. Do you have mold-free places to live that don't trigger asthma? Do you have functional bathrooms and kitchens? Is it affordable for you to live? Once you pay for your rent or your mortgage, do you have enough to be able to afford other necessities in life? What are the neighborhood conditions like? Do you have places to walk? Do you have destinations that you can go to? How safe is it? And the housing stability, being able to stay in the same place, is really important for social connections. And of course, all of these pieces are interrelated, but knowing the concept of that they're related, but not really being able to tease out why and how. So some of the questions is, could we link information to find out? We also knew from previous static linkages that 75% of adults who lived in public housing received Medicaid, but we didn't have any way of being able to look at how are they utilizing, how are their health conditions. And while King County often performs well overall when you're looking at health compared to other counties or states, our small area analysis showed we have a lot of geographic, income, and racial disparities that rival disparities across the country. And we really wanted to be able to dig into those components. In addition, the housing agencies are looking to improve health and well-being of their residents. And we also had another thing that happened to align very nicely. We had the opportunity for some Medicaid transformation, bringing the accountable communities of health that provided opportunities for incentives where you could align the healthcare and housing. Okay, next slide, please. And so the partners on this project are Public Health Seattle King County, which I represent, two of the major public authorities in King County, Seattle Housing Authority and the King County Housing Authority, who shared their enrollment files with us, and the Washington State Healthcare Authority, who had the Medicaid enrollment and claims data that we used for this. Next slide. So our project goals were to help the Public Housing Authority have a better understanding of the health conditions of their population and to enable them to start looking at some of their program and policy development and evaluation. We had all of the tasks that we had really rolled up into these three major tasks that we wanted to be able to link the Medicaid enrollment and claims data with the resident data. And just in case people on the phone are not familiar with it, Medicaid claims hold information from medical and counted from a provider. And we used the resident data from the moving to work form, the 5058 form, which is a slightly different form from some of the other ones that are used by HUD, the Housing and Urban Development. We also wanted to provide the housing authorities a de-identified data set and visualizations so that we had the health conditions that were coded for them. So they had enhanced in-house ability for assessment and evaluation. Rather than keep all the data completely internal, we wanted to really enable them to be able to look at the data. And our third task was to figure out how do we develop the methods to sustain this process so that we can update this on a regular basis, so that our housing authorities can take a deeper dive into the data and answer questions that previous static images had raised. Next slide, please. So we had three, our short-term, intermediate, and long-term. The short-term, in a summary, basically we wanted to have a better understanding of housing in the health department, and we wanted the housing departments to have a better understanding of health. We wanted to bring housing to the table for the accountable communities of health and to really pilot this cross-sector partnership. There's a lot of interest in data being shared, but of course, all the normal difficulties that Darcy and Karen had discussed, we wanted to be able to address those. In the intermediate, we really wanted to have a systematized way of looking at this data, to be able to use the data that we were generating for planning and evaluation purposes. We wanted to share the methods, so whatever we developed, we would like for other people to see whether they can adapt and use. And we wanted to have more information on the housing and health relationship, particularly as it related to our particular county. And long-term, we're looking for the decreased health inequities, being able possibly to coordinate care, and to really impact the triple aim for lowered healthcare costs, improved population health, and increased patient experience. Next slide, please. And so what we did is we took the enrollment files with the goal of creating this longitudinal cross-public housing authority de-identified data set that allowed comparison of demographic and health conditions over time. And as you might imagine, there's a challenge of taking these point-in-time data and then trying to reshape them and create them to have a longitudinal data set. On the left-hand side, you can see how we combined both the King County and the Seattle Housing Authority data. We had to do some reshaping, some cleaning up, some standardization, link them together, figure out who moved in between. And on the Medicaid files, we restructured it to have a start and end date for enrollment. And then we cleaned up that enrollment file and we linked them together. And we had about 89,000 records that linked. Next slide, please. And so what this linked file has allowed us to do, we're using Tableau to do a lot of our visualizations. And we know, for example, that most children and adults in the public housing authority should be Medicaid eligible, but we don't know how many were not. Well, we knew sort of how many were not enrolled, but we weren't able to break it down by all these different categories. And we also were curious if we saw an uptick after the Affordable Care Act went into place. And we did see that uptick, but we see that there still might be room for improvement. And in these dashboards that we're building, we're allowing filtering by age, by the different agencies for both King County or Seattle, so they can look at their own, they can look at how they compare to each other. Looking at things of length of time in housing, because that is related to some of your health conditions. Being able to look at race, ethnicity, or do comparison of people who were in the housing authority and on Medicaid and people who were not in the housing authority but are also on Medicaid, and also looking at it by project type. Do they have a housing voucher where they are in an apartment somewhere, or are they in a project-based setting? Next slide, please. We're also generating some maps to identify enrollment opportunities, especially while open enrollment was going on. We wanted to be able to look at some of the spatial considerations of this and other disease patterns, because one of the questions are, is this a condition that's being experienced in the greater neighborhood, or is it a condition that's primarily being experienced by public housing residents? These are questions that we're able to answer after having geocoded the data and being able to look at maps. Next slide, please. And so the health data are still under a review before release, and so that's why what you have seen is primarily around the enrollment. But as a little summary and teaser, what we are seeing is that the public housing authorities serve a Medicaid population that have higher rates of chronic disease, injury, and adult asthma compared to the non-public housing Medicaid enrollees. We also are seeing different distributions of disease and opportunities for impact across the two PHAs. So how diseases are distributed across King County versus Seattle is different. We see in both that the avoidable emergency department use remains off target. If we're trying to get people into primary care, we think that there's some work that can be done there. And that there could be also room for improvement on enrollment into Medicaid. And one caveat of interest is we were looking at some of this information just at a global Medicaid level. What we see from our surveillance data, from our behavioral risk factor surveillance data, when we stratify by Medicaid, prevalence of some of the chronic conditions appears much higher in the BRFS than it does in the claims data. And so that's one of the caveats that we want to keep in mind when we're thinking about how to use this data, because it falls below the general population measures. Okay, next slide, please. Some of the lessons that we've learned is that bringing the right people to the table is essential. You know, as Darcy mentioned and Karen mentioned, data sharing is always a challenge. It takes more time than expected. Robert Wood Johnson Foundation says that data is shared at the speed of trust, and I always quip it's with the brakes of bureaucracy. But having people at the table who can be the people who keep elevating the need for this data sharing and help to push the data sharing when it gets stuck is really important. It's also helpful to have them there to really understand the data. There are many caveats to the housing data that we would not have been able to understand if it hadn't been for their analysts being there with us. We found that it was really interesting because public health thinks about data at an individual level, whereas housing often thinks about housing as a household level because that has been their unit of measure. And even when we thought we were getting quote unquote standardized data, there was a lot of cleanup that was still required. When possible, if you can fund the partner to do the work, that's really important. There is no free data lunch. There's lots of valuable insights to the data. Trying to figure out what are the most important components to display and discuss is an interesting discussion that we are still in the middle of having. But it's great for the partners to have the opportunity to drill down in their data. And we're also finding the housing sector is really excited for the opportunities to understand their client health and well-being. And so being able to build off that excitement is also brings out a level of enthusiasm for us as well. Next slide, please. And so what we're continuing to do in the future is to do more analytics. We want to share the code for how we've processed the HUD 5058 form. We're pursuing the non-federally funded low-income housing, so the non-HUD data. We're trying to look at bringing in the Medicare data because there's a number of people over the age of 65 in housing, and we're not able to look at many of their claims. And for people who may be dual eligible, we may only be getting a portion of their claims. And we're going to revisit the extract that we had from the Public Housing Authority. One of the issues that we had in terms of resolving numbers with them, they were using some different fields that may be helpful for improving our data accuracy. Next slide, please. And so I just wanted to acknowledge Robert Wood Johnson Foundation and the DASH team for funding this project. Thank you to the Illinois Public Health Institute and Michigan Public Health Institute for all their feedback and connections that they've made. Thanks to the Washington State Healthcare Authority who gave us the Medicaid data that allowed us to be able to do this in the first place. And to our fabulous housing partners, Sarah Oppenheimer, Alexis Worth, Danielle Bessemer, Kate Allen, and Betsy Lieberman, and to the superstar public health analysts that have done such a great job with this, Alistair Matheson and Lynn Song. And thank you, and I'm happy to answer any questions.
Great. That's really exciting work you have. And I do have a clarifying question for you. You talked about that front end piece of really understanding the data from the source, and that often that I'm going to say data steward or representative from that program really has a depth of understanding. Did you pull those individuals or representatives in the analysis stage as well for that interpretation piece?
So for all of the housing work that we did, yes. For the claims piece, we've been trying to develop some of that expertise on our own, leaning on other people who also had some expertise. The claims piece has primarily been outside of the DASH grant because we're also doing some work with our accountable communities of health. But the public housing analysts have been an important component of that. when we were far off with some of our enrollment numbers, they were able to look at that and really delve into the data. We had this number of people, they had that number of people. We could pull and say, like, why, what happened to these people? And so that was one of the components. Like, for example, people port in and out of the different housing authorities. And at one point there was some of the port fields had not been given to us, or there had been a field where we didn't have some of that information. And so, or when we were looking at, because the housing authorities review eligibility every 1 or 2 years, depending on the classification of the household. And so we were imputing some of those dates, but we had not been imputing all of them correctly because we had needed some additional fields. So if we had not had them at the table, we would have had some erroneous information that went out.
Wow, that's a really good takeaway, because there can be a lot of discussion about the front end and getting the agreements and the participation, but you carried that all the way through, and it sounds like it really benefited the whole effort. So I'd like to transition with all of the panel members now into Q&A. And we've had great participation from our audience, and I'm hoping we can get to all the questions. I'm going to rotate amongst you and just pose the questions that have come from the audience. And to start with, I'd like to ask Kevin. We had a question from the audience asking, are population mobility and or transient populations considered, and how important would it be to understand or interpret the data to include the data from adjacent geographies?
Yes, so one nice thing about the neighborhood tabulation area is that the Department of City Planning sort of oversees it, and they are the agencies that is tasked with population dynamics in New York City, and so population mobility is important to them, and capturing it is important to them. That being said, it is very difficult to capture using the data sources available those sorts of short-term population dynamics, and so to a certain extent, we're as the health agency, we're deferring to the official city demographer for their expertise. And I think even Joe Salvo, he's the city's demographer, I think he would even recognize that it's a difficult task, but nonetheless, it's being handled by the right person in this instance, so that we're not having to do anything on our own that may or may not wash with the city agency that's tasked with following them.
Great, thank you. So the next question that came in is for Karen. And the question is, was there data that estimated quality of diet or the amount of exercise that residents did?
So unfortunately, when you're using claims data or the percentages that we're getting, it's very hard to look at progress or to look at that level of data. At this time, however, we also did our own behavioral risk factor survey. So we got a large amount of that. And obviously there's self-perception questions in there and some of those types of things. And we're now doing small area analysis using that data, which will allow us to make estimates at the census tract level, similar to the 500 cities work that the CDC did with Robert Wood Johnson. And once we can add that, I think we'll have some of that level of data.
That's great. And did your survey come about as a result of the work you were doing here, or is that something that was a separate effort?
No, that was a separate effort. We had to raise about $500,000, and we did 9,000. So.
Wow. All right, great. The next question I have is for Darcy. And the question that came in from the audience was, for the 20% of individuals with 2 or more falls-related ED visits, do you also access cost data? And is cost data being brought into these questions more broadly?
Well, thanks for the question. So we have not started accessing cost data yet. However, the data are available through the Maryland Health Services Cost Review Commission. So right now we're just focusing on the falls-related visits and trying to get that data infrastructure up and running. But I love the idea of bringing the cost into it, especially because we have this unique that actually includes that information. But of course, like all, local health departments and health systems, we think a lot about the frequent flyers that come through emergency departments and hospitals. And so we're certainly very interested in the folks that are experiencing more than one visit in a given time period.
Great. Now, Karen, I had a question from the audience for you, and it is, what were the known limitations of FRED as a simulation model? And a second question that came in with it is, what data do you wish you had been able to collect but just didn't have access to?
Oh, so my sense of FRED's limitations is that the population doesn't grow and age at this point in time, and I know that they're working on it. I think the other thing is that there's sort of a bigger question of whether or not you can use synthetic modeling for something like chronic disease where you don't have the infectious component that you have with an infectious disease. So I think those are some of the big ones. They are currently adapting the model specifically for chronic diseases and also building in this kind of aging process so that literally you sort of see a population shift and change and move and grow and those kinds of things, which will, I think, make it a really amazing tool. The last question you asked me, can you repeat it again?
Sure. The second part is, what data did you wish you had been able to collect but didn't have access to?
So I think the EHR data would probably be the big one for us. Not being able to look at progress over time, which is something that you really can't get out of claims data. So next time we collect the data on the number of people who have hypertension, it's not going to show us that there were fewer. It may actually show us there were more, even though there was potentially improvement in their management of their disease. So I'm really interested in getting access to electronic health record, and we're working on that. We'll see how that goes.
Wow, that's great. And that bridges into a question I have for Amy. The effort you were talking about focused on de-identified data, but given that you're talking about actual housing units and families that are being served, I was curious if any discussion about identifying the data so that specific interventions can happen has been discussed at all, or if that hasn't come up in the course of your presenting your results.
Well, the issue with identifying people is that we are, because we do provide direct services, we are a HIPAA-covered entity, and so that we would have to address those with the HIPAA compliance. The other consideration is if there is anything that had to deal with substance use or mental health, there's a different regulation, the CFR 42. So there were a lot of significant limitations around how that data could potentially be shared. And we thought that, as this initial look into the cross-partnership or cross-sector partnership, being able to look at the data, starting off with the identified data, what could you drill down? Because it may not necessarily be that they need to work with individuals at this time, because if they're developing programs and services that they can see, there's a high percentage of people who have diabetes in this housing group, then we can go into some education, we can do other information, we can collect qualitative pieces, or we can figure out what sort of services people might need. So there's a lot of intervention that can go on without having to share that individual level data. At this time, the answer is no. But when we think about in terms of the care coordination piece, for the accountable communities of health, I think that could be a possibility, but we still have to figure out some of the data sharing pieces around that.
Yeah, absolutely. And you're so right that it does become more complex as you start looking at the laws and regulations affecting different data sets. But it's fantastic that you've had the ability to move to action from the de-identified set and gotten so much value. I have another audience question, and this one is for Darcy. And the question is, what are the main components of the falls strategy, and what are the most effective interventions to prevent future falls?
Yeah, so thanks for the question. There are several different types of interventions that are known to be effective. So home modification is one of them in terms of removing throw rugs and putting safety bars in the bathroom to prevent slips. Vision screening is another effective intervention, so just making sure folks can see safely around their area. Medication management is also another effective falls prevention intervention, and as well as exercise to improve balance, as well as strengthen muscles. So all of these different interventions are being used by our partners across the city in different settings. And for instance, in the zip code that I mentioned, 21211, there's a building there. It's an older adult housing complex where they have over 60 falls that have occurred among about 40 individuals in that building. And so the group is specifically looking at what they can do within that building to reduce the risk of falls, if it has to do with modifying the units or perhaps offering vision screening to the residents. So I think or maybe offering folks an exercise class. So I think the intervention kind of depends on the unique situation and what makes the most sense. And in terms of the citywide fall strategy, a lot of it is looking at how can we use the data to help inform what's going on across the city. So obviously not just what the health department is able to do and able to fund, for instance, through our senior centers, but also how the data can be shared with community partners and inform the different projects and interventions that they have in place. So it's really a strategy that will be bringing together different city agencies as well as partners, hospitals, academic institutions, with the goal of using these data to better inform our falls prevention activities.
Wow, great. Thank you, Darcy. I do have another question for Amy, and this is a very interesting, policy population health question. And so a member of the audience asked for Amy, I'm curious whether any of those whose projects focused on housing and cardiovascular disease or other variables impacted by smoking are aware of the new HUD regulations for multifamily housing units forbidding smoking in their housing and some common areas. Are there opportunities to share your data with HUD to facilitate the implementation of this policy change? And this person said the policy is being met with some frustration and resistance in parts of our state, Texas. So I think, Amy, you were specifically talking about housing, but others of you mentioned things related to smoking. So Amy, would you mind starting with an answer?
Sure. Well, actually, quite interestingly, one of our early partnerships with our housing authorities was we implemented a policy systems and environment change that prohibited smoking in all public housing. And that was about 4 years ago. So that's one of the previous partnerships we had with them. So they are currently all smoke-free.
Great. And do you think, has there been any discussion about a desire to share the data with HUD about what you have seen and learned?
We have not had that discussion. I certainly can bring that back to the team. One of the things that we did note, it was it's correlation because we didn't have any data. It was, in some ways, it's a shame we didn't have some of this health data prior to this because there was actually, the year after it went into place, there was a significant decline in the low-income smoking rate in our population, but we can't directly attribute it to anything that occurred because we were not measuring that. But if HUD is interested or people in Texas are interested in how we went about that, we're happy to share. It was one of our CDC-funded grants where we're doing some policy systems and environment change. We actually had some really nice letters that came in from people in the housing communities who were so appreciative. People who needed to stop smoking in their houses weren't so appreciative, but there was a fair amount of community acceptance of that decision. But I certainly thank you for the suggestion to take some of our learnings back to HUD because I can have that conversation with our team. Thank you.
Yeah, that's great. And I suspect that you will have some folks reaching out to you after this webinar. That brings us to the close of our audience questions and Q&A. And I want to thank all of our presenters. It's really exciting to hear about how the integrated data, really looking broadly across sectors, is being put into action, and the kinds of insights you guys are finding and the depth of your work. It makes it really encouraging because, you've all kind of spoken to some of the uphill efforts that are required at the front end to bring data together. So with that, I'm going to hand it back over to Peter, who is our DASH leader, and give him the speaker stick for bringing us to a close.
Thanks, Gary. That was terrific. There's just no substitution for actual subject matter expertise, and your moderation and your questions were really great. Thanks so much, and thanks to all of the DASH panelists. I just love these opportunities. For those of you who loved it so much that you'd like to listen again, or you'd like to share this experience with your colleagues, the webinar archive and the slides will be available starting Monday at dashconnect.org. And so we encourage you to follow up there. I also want to encourage you to check out allindata.org. That gives you more information about what we're doing in our broader network, and that will give you information about yet a third way to be connected to us at allinhealthdoers.org. That's the online collaborative home for the membership of health doers. And if you're the kind of person who gets really excited about this stuff, you might want to consider joining us there. It's a great follow if you're on Twitter for _connect. Jennifer Frickovich and our team kicks out a lot of really interesting opportunities through that. Finally, I'd just like to say we really appreciate it. We'll have more webinars that will be almost as good as this one. You can see our calendar at dashconnect.org/calendar. Again, thanks to everybody for presenting, for your great questions, for your attentiveness. We wish you season's greetings, and thank you for your attention. Take care, everybody.